With defining national consistency and then talking about service specifications, for example, I can think maybe of CPAMS. There is a service specification, it is national. So we would want to be getting into different service specifications for the same service throughout the country, would we?
So that's the balancing point. I'm sorry, I'm taking all the questions, Tim. Do you want to answer that one?
Same answer.
So, I mean, that's a good example. So, you know, the underlying service specification is probably going to be the same for something like CPAMS, but how it's implemented at a local level may vary. So, you know, my experience in my area with that implementation, some pharmacists have a really good relationship with their GP, and they're working really closely with the GP and the patient to manage their warfarin and anticoagulant profile. Others are less well connected with the GP, so this gives us an opportunity to actually work much closer at a local level to work through some of those nuances and how that might work. And so how it's implemented at a local level, we need that flexibility to respond how that might work. You know, another example in our area, we've got a pharmacy that sits in the reception area of the general practice. They have direct access to the GP's medical notes, and they work really well as a team. So the CPAMS is a joint process between the general practice team and the pharmacy, where other areas they're not so well connected, and we want to get more of those sorts of models enabled.
So the idea behind those specifications is that there'll be a nationally similar specification, local implementation might vary. So no, we're not trying to have 20 different versions of the same thing, because that would be inefficient. And some of the other models we're talking about is there may be a high level specification nationally to give pharmacy certainty that these services will exist and they will be bought, but how you implement them on the ground will be part of a local conversation.
Sunita Goyal from ACC. I have a question on the professional services, maybe along the lines of Linda's theme. How do you envisage that actually evolving? Because I probably see it as supply meeting a certain time frame, all of that kind of thing. What is the service delivery specification for the professional service? Initially it'll be maybe patient understands the medicine. What if they don't? Is that going to evolve, or is that going to be Schedule 2 service or Schedule 3 service? How do you see that evolving? The reason I ask that question is because from what we perceive at ACC, it's not about who delivers the service, it's about medicines management and getting the outcomes from the service. So that's the kind of tack we take. So I'm just interested in how you see it going forward.
So we see this as evolving. So, you know, if you think of the mental health population and how they engage with health services, generally quite different in terms of some of the other patient groups we work with, particularly if they're with a NGO support service and that. So this model gives us an opportunity to actually work closely with like a mental health NGO to manage pharmaceuticals for the population they're supporting and caring for, as part of the broader team with the pharmacists and that around good medicines management, the health literacy aspects around that, and you know, it enables us to tweak and modify for those particular populations. So this is what this is all about, us responding to unique populations in a different way. I always talk in Auckland about the services I want to give in Remuera do not look like the services I want to give in Mount Roskill. You know, Remuera, I've got lots of people in suits, expensive cars. Go to Mount Roskill, I've got lots of recent migrants that are unemployed, English as a second language, all of those sorts of things. The model that we have at the moment doesn't respond to that population, and I want a response for that population to deal with the equity issues.
So it is an evolving model, and we see a number of options around those kind of things, where you can have the supply and then the advice and medicines management becomes a separate but connected. It's important that the two are connected. One of the other reasons for splitting them into Schedule 1 and Schedule 2 is because it enables us, and it comes back to Linda's question, it enables us to start funding that service irrespective of the link to the pharmaceutical. So we're actually funding the clinical advice piece, and it doesn't have to be linked to the dispensing of a product. And that gives us far more options in terms of how we can resource pharmacists to practice in their clinical space.